I'm Dr. Derek Lee. I'd like to welcome Dr. Kevin Smith. Dr. Smith is a pediatric orthopedic surgeon at Canadian Children's Eastern Ontario Hospital. He's also an investigator at the CHEO Research Institute and an assistant professor at the Department of Medicine at the University of Ottawa. Welcome, Dr. Smith.
Thank you very much, Dr. Lee. It's a pleasure to be here discussing this with you today.
Excellent. Can you talk a little bit about your career path and how you became interested in medicine at the beginning and eventually your path to becoming an orthopedic surgeon?
Absolutely. I mean, I grew up in south in Canada as you can. I actually grew up south of Detroit, so south of Windsor. And when I was in high school, my plan was going to take over my dad's business. He does kind of some woodworking and was making interior doors and trim. So I was working there in the summer and after schools and on weekends throughout high school, until one day he cut his fingers off on a saw. And that was kind of the big career move for me at that time, because my mom said, Kevin, listen, you are not allowed to do this anymore. You have to do something else. So I'm like, well, fine. If I can't kind of continue in carpentry and woodworking, I'm going to go into medicine instead. And that's kind of where my kind of big career shift moved at that time. I was always interested in helping people and kind of getting involved. I always liked working with my hands. And so got into medical school after doing an undergrad in biochemistry in Ottawa, and basically took it from there. I'd always thought about surgery, and then when I did my musculoskeletal block, I was really interested in the human skeleton, the muscles, motion and function, and that's kind of where my passion really went from there. I initially thought about cardiac surgery, but there weren't really any jobs at that time. So, but once I found kind of orthopedics and that you could work with saws and hammers and screws and stuff, it was really my passion, because that's kind of what I did growing up with my dad. So it's kind of a natural kind of path for me at that time.
I know you spent a year at Texas Scottish Rite Hospital for Children in Dallas, which is, because I've talked to other surgeons as well, and it's quite a prestigious hospital. Is that where you learned thoracoscopic surgery?
Yeah, absolutely. I mean, I did a 5-year residency at Western, and then I was lucky enough to get into Scottish Rite. I think they thought I was somebody else, and then I got in. But, you know, it was a phenomenal fellowship. It was one of the best training years of my life, to be honest. The mentors that we had down there with, you know, Dr. Herring, Dr. Succato, Dr. Richards, Dr. Carroll, and everybody else there, they're just such amazing people. And that's really where I got interested in spinal surgery. You know, I did some in residency, but you don't understand it as much. And then when you really dive into it and go into the depth and the education and the surgical experience there, that's when I got interested in spinal surgery. And with Dr. Succato, we did some thoracoscopic approaches. Now, we never did any tethering per se, but that's where I learned kind of the anterior thoracoscopic approach, where we did some releases and different little procedures that way.
Do you find that with that approach, you have to be able to have that skill set in order to do tethering, correct?
Yeah, well, I mean, like you've seen, there's kind of two different fields in the tethering. There's the people that do their own approaches, such as myself, and I think a lot of the other Canadian surgeons, and other people that have approach surgeons do it for them. So they'll get general surgeons or thoracic surgeons to come in and deflate the lung and do the exposure for them. And so I think you have to have an understanding of it, but you have to also know your own limitations. And if you have people that are better at it than you that can get you access, then it's all about knowing who to ask and then how to do the rest.
Okay, it makes total sense. When was your first exposure to VBT?
Yeah, so I mean, again, back to the thoracoscopic one in fellowship, I just found the anatomy absolutely fascinating, how much you could actually see through a scope once you deflate the lungs. It was astounding, really, kind of the anatomy. And then when I started practice, I mean, you've talked to a few other people, and I may be a little bit younger in practice than some of the other people that you've interviewed, and they've been great mentors to me throughout all of this. But when I started my practice, this is kind of when people would come up to us more and more and ask us about fusionless options for scoliosis correction. And that's kind of when I started getting interested in reading about it. You go to some conferences and hear about it. And then I had attended kind of a reunion meeting at Scottish Rite. It's called the Brendan Carroll Visiting Professorship. and Dr. Stéphane Parent was there and was talking a little bit about his experience with that. And that's kind of the first time that I got to sit down with him and really discuss things in detail about what it is. And from there, I just set it up. I'm like, hey, Dr. Parent, is it okay if I come to Montreal? It's an hour and a half down the road to come and learn this from you. And so from there, it's really kind of sprung forward, and I got to go and do some surgeries with him. When I did my first surgeries in Ottawa over 2.5 years ago, he would come down and do some with me, and that's really blossomed where we're part of a trial together for some implants for vertebral body tethering now.
Okay, well, since we're on that topic, how is that particular study going? You guys are maybe coming up to a year into it, or?
Yeah, we're at about a year now, and you know, it's a part of the future trial. It's a system that was really that Dr. Parent helped design with a company in Montreal, designed specifically for vertebral body tethering. As you know, when we first started doing this a few years ago, we were using kind of non-FDA, non-Health Canada approved devices, or that weren't approved. And we were kind of modifying the devices and having to kind of cut screws in the operating room to make them fit so that they weren't too long, because you don't want them too long to go into vital structures on the other side of the spine. And so, you know, since then, different companies have been designing equipment that are more specific to vertebral body tethering for use in adolescent patients that have smaller anatomy. And so, you know, the trial's going well. You know, we don't have any of our interim results available yet, but it's very promising.
Excellent, because I know I actually interviewed Dr. Parent as well. That's an upcoming interview. So we're just discussing a little bit of how the system was kind of designed from the ground up, as opposed to, like you said before, a bit of you know, horseshoeing it in from previous instrumentation. He mentioned that the profile is a little bit less high, so it doesn't protrude as much. And the tether is, of course, a flat, stronger tether as well, that supposedly hugs the anatomy a little bit tighter, right? And less shearing, I guess, with a lower profile. Have you found that that system is easier to use than the previous systems you were trying to use before?
Oh, I mean, absolutely. When you have a system that's designed for what you're doing, you have extra equipment that can help you and make it easier for you to access, easier for you to put the implants in. And like, for an example, like now the screws are the right size, we're not having to go on the back table and use a big kind of thing to chop the screws to the right length. So it saves a lot of time and it's a lot safer, right? Sure. But yeah, no, like you mentioned, with the new implant, with the MI Scoli implant, it's a lower profile, so it doesn't protrude as much, so we think that might lead to less lung irritation. And with the tether design, because it's a flat tether as opposed to a round tether, it really allows those tulips to be a little bit lower profile. Excellent.
Now I have a question for you, because the screws are supposed to go to cortex, right? Is that because the cortex or the outer layer is denser or stronger, and the screw is supposed to hold tighter? I've never asked anyone this.
Yeah, if you look at kind of the anatomy of bone in general, there's kind of two major types of bone. There's cortical bone, which is the hard bone. When you think of like the outside of the femur shaft, like that's hard cortical bone. And then you have cancellous bone, which is kind of more spongy bone, which is more what you see in the vertebral bodies. But on the outside of the vertebral bodies is this kind of more thinner cortex, so that hopefully you get a little bit more bite from them. So by having bicortical bite, that screw is more likely to have a good interface and then less likely to pull out or move in the vertebral body. And that's kind of what we want. We want kind of more of a stable fixation to prevent motion and to really kind of cause that tethering on the convexity of the spine for that growth modulation with time.
With the protrusion of the screw to the outside, to the far cortex, or I guess on the edge of the screw that's biting, is the screw kind of naturally dulled, so even though it protrudes, it's less irritating, or is it? I'm just wondering about the design of it.
And that's the nice thing about the new design of this being specific for it, is that you get the screw that's just the right length, so you can protrude 1 millimeter or 2 on the other side of the cortex. But the end of that screw is nice and flat. Whereas before we were having to cut it and then there could be sharp ends, then we'd have to try to file it down in the operating room. because the last thing you want is a big spike sticking out on the other side, especially when you're preserving motion so that those are moving, and you don't want that causing any rubbing on the other side. You know, there are reports even in previous anterior surgery of screws causing problems with different arteries or veins that could lead to significant complications in kids. So those is everything that we want to try to avoid and learn from other people's mistakes.
Absolutely. Now, what do you see in terms of the potential of VBT that other surgeons really aren't seeing quite yet, or maybe not acting upon?
Well, I mean, for me, I use VBT really as a growth modulation procedure. So I'm looking for those younger kids that still have 2-3 years of growth potential left to try and correct their spine a little bit, and then as they grow, they continue to grow straight. And so I think that the potential for this is phenomenal to try and preserve motion, because who knows what's going to happen 20, 30, 40 years down the road with a fused spine. Although there are some initial results showing good long-term follow-up after a thoracic fusion, you know, I think if we can preserve motion, we could hopefully give those people a better quality of life for their entire life. But I think the main thing for me is, you know, I think I'm mainly just doing the VBT on the thoracic spine for now.
Okay.
But I think the biggest bang for our buck at some point, once we develop the appropriate surgical approaches and the appropriate implants, would be to try and preserve motion in the lumbar spine. You know, that's where a lot of our motion comes from. That's, you know, I think that a lot of our functional motion comes from there.
Mm-hmm.
In the thoracic spine, we have the chest cage that's really kind of limiting a lot of the stuff that we do. And so once we find a good way to reliably tether the lumbar spine with long-term good fixation and correction, I think that's kind of where the best bang for our buck is going to be in the future.
Absolutely. Now, what would you consider your perfect parameters for that perfect tethering patient in terms of, sorry, go ahead.
Well, that's a great question. And, you know, I think it varies from person to person. For me, it's a growing individual that still has 2 to 3 years of growth left, that has a main thoracic curve. Especially in the Canadian system, I'm fairly selective with my patients. I usually don't operate on anybody that I wouldn't actually offer a fusion surgery on. So I'm going kind of, my surgical indications are really 45, 50 degrees and above. Main thoracic curve, where the apex is really around T7, T8, where we would just do kind of the thoracic spine. And then have a fairly flexible curve, no major congenital vertebral abnormalities. And for usually girls, it would be premenarchal, Risser 0, and a Sanders 3. And like I said, boys they're kind of more or less predictable in terms of how much growth they have left. And so same thing for boys, kind of Risser 0, 1, and preferably a triradiate that is closing versus one that's completely open. Because if you have too much growth left, then you can overcorrect.
Okay. So from your experience, you want to have a little bit more maturity in the boys in terms of when you tether?
Slightly.
Slightly.
But,
okay.
Yeah.
So maybe Sanders 3B-ish or 4 even, or?
Yeah, we still haven't figured that out. And to be honest, I don't think there's been too many boys that have been tethered. Out of my patients, I've done one, and I have another one coming up in terms of males. But most of the tetherings that I've done have been in female patients.
Okay. Do factors like spine flexibility factor into, and well, let's put it this way, what would you consider your max in terms of Cobb angle if there's decent flexibility left, good flexibility remaining? Yeah,
probably about 65 degrees, 70 if they're very young. But probably, you know, 60, 65 degrees would probably be my upper limit. I think once you get over that, you're asking that tether to do a lot of work, and I think you increase the risk of failure.
Okay.
But yeah, I think flexibility is very important, because what we want to do with that tether is really to get some partial correction at the time of surgery. And if we can't get that correction, we're not offloading the concavity and putting more pressure on the convexity of the spine. And so then when we're trying to talk about growth modulation, we really want to try and change that, put more tension on the convexity and take off more of that compressive forces on the concavity to try and get those growth plates to continue growing.
Okay. When you're actually in the operating room and tethering and doing the surgery, some surgeons try and correct, let's say you're dealing with a 50 degree curve, they try to correct to 50% and perhaps anticipate maybe up to 25% additional correction with growth to maturity over 2 or 3 years. Is that your similar approach as well?
Yeah, that's kind of what we aim for. Now, at the time of surgery, what we're actually trying to aim for is to have a 50% correction for when they stand up after surgery.
Right.
And so there are so many factors that I'm still trying to learn during this, is really how much do we correct at the time of surgery. And I found that, you know, we try to correct as much as we can without putting too much tension on the tether or the vertebra. And how much tension is too much, we still don't have a way to measure that, unfortunately. So what I do at the time of surgery is I try to keep less tension at the top and the bottom of the construct, put more tension in the middle. And I really try to get the screws to be, and the end plates to be parallel at the time of the tethering. And we know that, you know, I could get it almost perfectly straight at the time of the OR. And then once we get them standing up, there's a certain sag that happens in the spine and the implants where you kind of lose that about 50% of your correction anyway. So I find it really hard to judge exactly how much to do at the time of surgery, because we do know that once they stand up, they lose a little bit of that correction.
Yes, gravity is nasty that way.
Yeah. And when you look at Dr. Newton's publications and his kind of 4 or 5 year follow-up, you know, I mean, there are some, there's quite a few cases, and Dr. Pagan and Mayanji have that too, where, you know, you see the initial correction and then over time, some of them do continue to correct. But when you look at the data and the summative data, it looks like most of the correction that we get is at the time of surgery. And I think there's probably some bone remodeling that's happening over time. I'm not sure how we're getting as much correction as we want after those 2-3 years of growth. Yes,
it's such an experiential technique in terms of, you know, the more you do, the more of a feel you get. It's very much of an art at this point, it seems.
At the same time, I mean, if we can take this 50-60 degree curve and take it down to 20-30 degrees and keep it there forever, you know, that's a curve that I would never operate on at 30 degrees. So, and those individuals, when they become adults, should hopefully have a fantastic life if we can get that curve a lot smaller and keep it smaller.
Oh, that's 100% a victory as far as I'm concerned as well. Of course, patients are patients and parents are looking for perfection, right? But if you can just reduce it by 50% and it holds, that's huge. Do you keep track of your stats right now in terms of tether revisions that have to be done, you've had to do over corrections and tether breaks? I was wondering if you could talk about that a little bit.
I've looked at that. I mean, I've used 2 systems, and I have, you know, almost 2.5 year follow-up on the older Dynasis system. You know, I've had a couple of the tethers break. Luckily, I hadn't had to revise them because they got fairly well corrected. And they went from, like, you know, 20 degrees, they had a tether breakage, then you can see that the change in the screws. And luckily, you know, they went from 20 to 25 degrees and they're skeletally mature now. So they're doing fantastic.
Okay.
You know, I have a couple other ones that, you know, unfortunately they have progressed, and it does look like they're from tether breakage, and they're on my list right now for a revision to a fusion surgery.
Because you've used the previous system and the SCOLITETHER system, have you noticed any difference in terms of how the tether is behaving, in terms of the strength of it, or if one is breaking more than the other as yet, or is it just too early?
Yeah, no, I mean, the results are still too early right now. You still have to kind of look at that in more detail. So I'm curious. I mean, I really enjoy working with the new system. It's very easy to work with. The tether is it's easy to handle. It's easy to get that tensioning down. But those are all factors that we're looking into. You know, when we're introducing kind of new technologies and new equipment, there's very stringent guidelines and very important things that we have to follow. And this is a Health Canada approved trial. So all these kids that are coming through, you know, we're taking very good preoperative measurements. We're documenting everything we do at the time of surgery. We have very stringent postoperative directives that we have to follow in terms of measurements, in terms of how the patients are doing, medications that they're taking, any complications that we're reporting. So those are all things that we're looking at and monitoring closely.
In terms of tethering, some surgeons feel that it's basically a growth modulation technique, right? And that if you move out of that growth modulation into more mature spines, and it wasn't really, the technique wasn't really built for that. Where do you kind of sit on that spectrum yourself?
I'm on the growth modulation spectrum of it. And, for me, my mind is very kind of, carpentry plus science, right? And so it makes sense to me that if we can correct something and apply the tension on one side, offload the other side, with growth, we could hopefully change the 3D anatomy of the vertebra. We've been doing this in the lower extremities, where we could modulate growth plates to get legs that are either in varus or valgus to grow straight. And so it's obviously a lot more complicated in the spine because the growth plates are at the very ends of the bone, and you can't just kind of tether the growth plates themselves. So you have to span the discs, and there's a lot more motion instead of like a 2D motion around the knee where you just have flexion extension. You have like basically 360 degrees of motion around the spine. And so to tether and modulate these growth plates becomes fairly complex when you start thinking about it. But I think that if we can at least modulate the growth plate, change the shape of the spine and the vertebra, then I believe that those changes will lead to permanent correction of the scoliosis, which is what we want. And then eventually, if you look into any biomechanics, any material that you cycle and load millions and millions of times, which these active kids will do to their spine, will break. So I think it's a matter of time before these tethers break. We don't know, 1 year, 3 years, 10 years, but at some point I imagine they will, just from purely like mechanics, right?
Absolutely.
When we talk about tethering skeletally mature spines, I just don't see that remodeling potential, and I just see a failure kind of down the road. They were relying purely on the tether for the correction, and at some point that will fail. Okay,
because I guess for what kind of breaks my heart is a little bit is that with these kids going, to higher standard score and just missing that window, right? It's such a shame because if their timing is off, then it just removes a little bit of an option. Do you see perhaps, Dr. Betts, he's on the other end of the spectrum in terms of more mature spines. And I know a lot of surgeons are kind of waiting for him to release data for his tethers, right?
Yeah.
If that data becomes a little bit more on the positive side, do you think it would ever be possible to tether maybe adolescent mature spines one day, or is it basically just a material science tether issue because that's all that's holding it?
Yeah, until I see the science and the long-term outcomes of that, then I'm open to a lot of stuff, Dr. Lee. When I started my practice, I thought, oh, tethering, that's crazy. And then when I started looking into it, I'm like, this makes sense, So there's a lot of stuff, and depending on patient asks and kind of what the science is out there, and if it starts to make sense and if it's explained to me or shown to me in a different way with good long-term outcomes, then yeah, anything's possible.
Sure.
But I mean, I think what you brought out is an important thing, is that, you feel like you missed the window, right? And I think tethering in North America, especially Canada, is pretty new. And so I think this puts the emphasis on making sure that we're seeing these kids early, that we're screening these kids early, that we're educating families and family physicians to be looking out for scoliosis. And when we do see it, to put them in contact with the right people to talk about different methods. It's educating the surgeons across Canada, the United States, and the world about different techniques that exist. And, listen, if you don't do the technique, but you know somebody that does, you can refer them on. And that our goal is to look out for kids and give them the best care possible, right? I know my limitations. I have limitations that I have stuff that I can't do, and I'm more than happy to refer those kids to people that can do it. And so it's all about the screening, finding these things out early so that we don't miss that window like you were talking about.
I agree, because even with my son's case, um, I missed his curve and I'm a chiropractor, which is kind of pathetic. But you don't usually look at your son's back all the time, right? It was that once he hit 25 degrees, and it was actually caught in a chest X-ray because he had a bit of a persistent cough, right? And that's when we picked it up. So it's so easy to miss. I wish they didn't get rid of the school screening.
Yeah, no, I agree, and you know, there's pros and cons to that when you look at it in the long run, right? With the school screening, a lot more kids were getting X-rays, so they're getting exposed to radiation that they never needed. Unfortunately, we do see that now without the school screening, that some kids are coming in with bigger spines and needing surgeries as opposed to needing a brace when they're younger to prevent a surgery, or having other surgeries to preserve motion and prevent fusion. But you know, you're not the only one, Dr. Lee. I've had a lot of patients and a lot of parents that come and, you know, they kick themselves in the butt. How did I not see it? Well, you know, you see your kid every day, and you won't notice a small gradual progression until it's like, whoa, like, what is that? And, you know, especially living in Canada for 6 months in the year, they're wearing sweaters and you don't really see their back. So, you know, I see this a lot. And, you know, oftentimes for us, it's not kids that are coming seeking us out to talk about tethering. Usually it's parents. Because, you know, they want to look at different things, or they've had a family friend or a cousin, or they know somebody that's had a fusion surgery that, you know, they have all this chronic back pain. And so they want to look for other solutions. And that's kind of what we're there for, is to help educate and help provide different access to services.
Okay. I was wondering if I could touch on another topic, controversial topic, which is basically disc release. Again, you have one side of the spectrum that, you know, are quoting animal studies in terms of, you know, if you put a needle into a disc, it compromises the disc structure and leads to degeneration. And the other side, with respect to tethering of more mature spines or severe curves that are stiff, that you need to do a disc release in order to reduce the anterior column so you can derotate as much as possible. Once again, where do you fit on in terms of that spectrum?
I try not to look at the disc. Again, for me, it's all about preserving motion. And I think when we touch one of the major things that helps with the motion, it could affect it in the long term. It's like when we're talking about the posterior surgery, when we do fusions, when you're exposing the bottom, you want to try and avoid the facet joints. If you look at a facet joint wrong, it can fuse, and then that affects motion as well. So I think it's pretty much the same in the front. But now a lot of that stuff with the disc and the disc health, I mean, is not as much about from the anterior surgery aspect. So I'm looking forward to seeing the long-term results from those studies too, to see what the disc health really is like from those kind of disc release surgeries. Okay.
Now, in terms of spine biomechanics, there's, you know, the theory of anterior vertebral overgrowth, which increases the height of the vertebra in the front, and when you have that going on at multiple levels, you produce the hypokyphosis, maybe lordosis, and in order for the spine to kind of lower the anterior column, it rotates, and that's how you drive the scoliosis. There are other surgeons I've spoken to who feel that it is an anterior column issue, but it's more of a disc wedging issue that drives that, especially with growth. What's your perspective on that?
I haven't totally figured this one out yet either. And, you know, it's a great question. And, you know, is it the chicken or the egg, right? Which one is it? And at the end of the day, I mean, I'm not sure if it matters. I think as long as what we do need to know is more the anatomy and how things change over time, and try to find out how to reverse those changes. We know from like the Hutter-Volkmann principle is like if we apply a tension on one side, hopefully we could affect the growth of the disc or the growth of the growth plate on the other side to kind of accelerate and correct. And so, you know, do we try to sheet our screws a little bit more posteriorly and they get too close to the spinal cord with this surgery? Do we try to treat them more anteriorly, but then we have other risks with the arteries and the aorta on the other side?
Mm-hmm.
So we don't know where that happy balance is when we're putting our screws to see if we can help modulate that growth a little bit more. And so for me, that question is still out there, and I'm not exactly sure, but usually by the time they see me, it's too late. Whatever happened already happened, and we have to try and reverse it and correct it somehow.
Okay. Now, one question I was talking to Dr. Peter Newton about is he likes to do for lumbar curves, because we were talking previously about that's, you know, we're trying to save that as much as possible, right, in terms of motion, because those are the motion segments that have the greatest range of motion. And he's been doing quite a few of the hybrids in terms of thoracic fusion, selective fusion, and tethering the lumbar spine. What's your perspective on that? I know you're still in the process of the learning curve yourself.
Yeah, and I think that's the biggest bang for our buck, like I talked to you about before. I think preserving that lumbar motion is going to be very important. You know, until there's a technique that's been perfected for the lumbar spine, and, you know, I'm very interested in it. I plan one day to hopefully go out and learn that technique too. I've been trying to go out with Dr. Manji for a bit, but with the COVID stuff and all that has definitely put a little wrench in the travel right now. But it's definitely something that I'm interested in looking at and interested in applying to my patients for the right ones. And, you know, sometimes it's nice to be able to offer this surgery, but sometimes the hardest thing is telling families and telling patients that, listen, I'm very sorry, but unfortunately, you don't qualify for this surgery in my hands. And I think that across Canada, the vertebral body tethering surgeons, I think we've agreed fairly much on kind of similar criteria, and have worked fairly closely together to try and, you know, provide the same surgeries to the same people, and kind of keep our indications fairly narrow for what we believe in the current science right now. And so it's really hard for us sometimes to tell families that, like, I'm sorry, we know that you want this, but unfortunately, because of these curve characteristics, because of age, because of skeletal maturity, unfortunately, you don't qualify for it in our hands. And sometimes, like I said, that's just the hardest thing, right?
Absolutely. But the more I've talked to surgeons, the more I've realized that Canada is so lucky to have so many, well, I shouldn't say so many, but some top surgeons who are doing this, because, and I have to say as well, it seems to be having more double degrees in Canada. For instance, Dr. Ron L. Hawari has a mechanical engineering degree. Dr. Prawn has a PhD in biomedical engineering. And so it's all you guys who like to work with your hands and like the physical nature of it as well. So I think in Canada, we're so lucky to have surgeons who are pushing the envelope as well.
Oh, yeah. I mean, for me, I've been lucky to have them as mentors, right? I mean, Dr. Manji, Dr. Pana has been great. Dr. Alawari, you know, I've traveled, I've talked with them all and collaborated with them on different things, and, you know, getting advice on different patients. I think that's the important thing, especially, you know, they have quite a few more years experience than I do. You know, I've been in practice for almost 5 years now. Okay. And so kind of learning this stuff is important, to have good mentors and good people to help guide you, to try and do it in the safest, most precise, calculated way possible. And, you know, it'd be nice. I wish I could just offer it to everybody that comes in to see it. But to kind of stick to what we do and the why, I think, is important as well for now.
Okay. Moving on to another type of non-fusion surgery with Apifix. Have you done any Apifix procedures, or do you plan on doing any in the near future?
Yeah, I've gone to Halifax. I've done a couple with Dr. Alawari. We've done a lab together. I have a couple people on my surgical wait list right now for the Apifix. Now, the biggest thing with, you know, when we're talking about kind of health and surgery and the Canadian system, there are different limitations compared to maybe our neighbors in the South, where we have different financial limitations imposed from our hospital. And especially in spine, a lot of that comes from implants. And so the Apifix, unfortunately, is a little bit more expensive than, say, a fusion surgery. So we have to justify to the hospitals, like, well, why would you do this surgery that costs 2 or 3 times as much money versus this other surgery, and what are the benefits of it? And so, you know, for me, it's fairly easy. I'm like, listen, we're trying to preserve motion in the spine. We're applying these to young people that are still active, that want to remain in sports and do a lot of activities, maybe for the next 5, 10, 15, 20 years.
Mm-hmm.
You know, so I think preserving the motion and kind of these are what these kids and their families want. And so we should find a way to provide it for them. And so I'm working with my hospital and our hospital foundation and kind of hopefully the local governments and stuff to try and find ways to fund these procedures for these kids. Because as you know, they just can't pay privately for it in our
Mm-hmm.
Canadian healthcare system.
Okay. With the Apifix, what do you like about that particular technique? And I know that Dr. Ron El Hawari basically released a publication in terms of using it for immature spines. And it did show some growth modulation occurring. And the correction was similar to VBT in around the 50% mark. How do you look at that as maybe an option in terms of over VBT?
Yeah, I think they're both options.
Mm-hmm.
You know, what I prefer about the VBT, we can do it through still a fairly minimally invasive procedure thoracoscopically.
Mm-hmm.
You know, the incisions are smaller, the recovery is pretty fast, and we're not fusing any levels. You know, we're going on the anterior aspect and giving a compression, which also can help with the kyphosis. And then when we talk about the Apifix, I think what I like about it is still preserving motion. It would be nice to see how much motion it does preserve compared to VBT. You know, we're having a tendency more to now, when it was first designed, was really putting it just at the apex on a couple levels. But I think we're learning that you have to kind of span it a little bit more.
Yes.
So now we're kind of going more kind of end to end, and then sometimes fusing one level at the top, one level at the bottom, and then distracting it. Again, there's a kind of a little kind of like a ceramic rotation that allows motion between the screw and rod interface. Because we know based on previous experiences with a single rod that if you don't fuse that rod's going to break, right? And that's based on our kind of early onset fusion list, just trying to correct things. And those rods break. So hopefully with this kind of lower, or this motion interface, we'll preserve the lifespan of that rod. And the other thing is that it has a built-in ratchet with it. So you can dial in the correction you want at the time of surgery. And if the child is still growing with certain specific exercises, they can ratchet that rod. So that rod will grow on its own without having to go back and do surgeries, which could lead to more correction, which is kind of interesting.
Yes, it's an interesting concept.
But again, I think that with any biomechanics, you know, it's like a total hip replacement. The total hip replacement, the best surgery that we have in all of orthopedics in terms of patient outcomes. But again, when you put that total hip after 10, 20, 40 years, eventually things wear out. And I think it'll be the same thing with the Apifix. I think at some point, when you cycle it enough, those materials will wear and will fail at some point.
Okay.
Hopefully by the time they fail, the patient has been through kind of their main active aspect of life, and we've given them a better quality of life during that time.
Okay. And do you look at Apifix as more of a immature or mature spine technique, or there's overlap between them?
Yeah, I think there's some overlap.
Mm-hmm.
You know, we're still trying to figure that out. Again, if we can kind of prop that up and on the concavity of the curve to prop it up, if they're skeletally immature, hopefully they'll remodel over time. Mm-hmm. And there will be some permanent changes to the vertebral body shape, which will lead to a permanent correction, which I'm not sure we'll see with just in the skeletally mature.
Okay. Now a question that's local to Ontario, and that's with respect to, you're the only surgeon in Ontario who offers VBT. Do you see that changing in the near future at all?
Well, it actually has changed because one of my colleagues here at CHIO, Dr. Andrew Tice, is doing it as well. So, and we're basically doing them all together because what's better than one surgeon doing spine surgery? Two. And when you both have an interest in it, it definitely helps. We can kind of give each other pointers and help each other out. So at CHIO, we actually have two spine surgeons that are doing the VBT technique, and we work together on kind of this program that we're developing. But yeah, in general, I think there's some interest out there. I'm talking to some other surgeons throughout Ontario that have an interest in it. Okay. You know, from London, Hamilton, Toronto. They're all interested, but you know, to take that leap, and for me to take that leap too, it was pretty big. I had a lot of local support from my chief of orthopedics with Dr. Willis, who's just a fantastic individual and mentor. Dr. Jarvis, one of my other spine surgeons with decades of experience, you know, was interested in it and was there to support me. And so just taking that leap and going ahead with it, it's a big step. It's a big step for the individual surgeon and for the hospital to get in new implants and to do a cost analysis on it as well. And I was lucky enough that I was trained with a thoracoscopic technique in my fellowship. And, you know, I don't think that a lot of surgeons in Ontario are comfortable with the thoracoscopic technique right now. So there is a big learning curve for that. So luckily, I didn't have to go through the thoracoscopic technique learning curve and the VBT learning curve at the same time because I already had experience with it. But I think, you know, when you look at bringing in new technologies and new innovations, you have the big innovators, the first people to adopt it, like Dr. Newton. And then you look at, then there's the early adopters, and then, you know, I think I'm of a lot later aspect of the early adopters. And then there's the big curve where you then have a lot of the people that have adopted it, and then kind of the stragglers, right? So I still think we're on that up curve for VBT. It's still very early, and I think a lot of people are just waiting to find out the best way to do the surgery, the best implants to do the surgery with, the best patients to do it on, and how to do it, and learn the tips and tricks on what to avoid.
And there seems to be a lot of innovation by the different instrumentation companies like Zimmer and Globus, for sure. Because I have an interview with Zimmer Biomet coming up, so that should be a lot of fun. I only have about 1 million questions for them. I've heard that, well, with talking to them, they're really, really strict on who uses their technology, and they bring surgeons down to the US to train them as well. Are you interested in going down that path as well? Just to
I was scheduled to be there in April, I think.
Oh, is that right?
Obviously, with the pandemic, that put a wrench into things. So I've been talking with Dr. Mayanji in Vancouver, who's been using it to kind of get a tutorial on it to be able to use it as well. I mean, you know, I'm interested in using different techniques and different implants to see what they're like. And I do have experience with the previous implant from Zimmer, with the Scoliosis system. And it sounds like it's fairly similar in terms of the technique, and there's just some modifications that it made to it. Obviously, for them to redesign a whole implant system would be very hard to get FDA approval for. And so they had to take the current system that they had and make minor modifications to be able to kind of get it through the system a little bit faster.
Okay. Now, last question. If you're looking into your crystal ball and you look down the road, maybe 10, 15, 20 years, do you see where do you see the major advancements in scoliosis surgery?
Yeah, I think there's going to be a lot more talk about fusionless surgery for scoliosis to try and preserve motion of the spine. We're actually doing a study locally here with the University of Ottawa, looking at motion of the spine and comparing VBT to fusion, to AIS without surgery, to normal kids without anything, with normal spines, to really see what happens with the motion over time. So I think it'll take more studies like this to really kind of get through to follow this, to see, well, how much motion are we actually preserving, and where is it most important to preserve this motion? And I think the biggest thing going forward will probably be in the lumbar spine. And so I think time will tell. The problem, if we tether the lumbar spine from anteriorly, we're kind of compressing that anterior column, and we're losing a little bit of our lordosis, which is kind of what you want in the lumbar spine. So we might have to kind of change our approach a little bit, or see if there's a way we could tether more posteriorly, maybe.
Okay.
So that's kind of what I see coming out in the future.
Mm.
More and more talk about fusionless surgery, and I think that there will be some struggles along the way, but I think it's important to continue persevering.
Excellent. Sorry, I got to ask you one more question.
Oh, ask away.
Because I know of one or two surgeons in the U.S. who are actually doing for the lumbar spine. They do posterior tethers in terms of trying to maintain, I guess, that lordosis. But it also seems to kind of reduce a lot of the flexibility too, right? In forward flexion. So do you see that as maybe a possibility, or maybe trying to do the anterior approach still, but just aiming more for posterior placement?
No, it's great, and I think we need better biomechanical models and more experimentation and a little bit more experience on it.
Mm-hmm.
But obviously, I mean, the ideal goal for scoliosis correction would be to get a straight spine that moves perfectly normally, right? When you have a very crooked spine, to get it straight, unfortunately, it takes some kind of instruments or something right now to get it straight. And depending on what you use, will definitely limit some of the motion because of the tension and the materials that we use to correct it.
Okay. Thank you so much for your time, Dr. Smith.
No, my pleasure, Dr. Lee. I think I thank you for getting us all involved. And, you know, we talk a little bit about kind of what our experience is, but, you know, these parents out there and these kids, it's all about them, getting educated and getting the right thing for them, supporting them when we can. And, you know, I have kids that sometimes, unfortunately, the surgery is not available in Canada. They've gone elsewhere to seek treatment, but I want them to know that we're still here for them, to follow them after their surgeries elsewhere, to try and give them follow-up and care, to make sure that we're still looking after all these kids, and we'll take the best care of them that we can.
Excellent. Okay. Thanks for your time. Have a great day.
All right. Take care.
Okay.
Stay safe.
All right.